Dr. Gwanzura will present, who is our senior registrar at Parenyatwa, will present a case that we saw at Parenyatwa this week. So let's allow her to present. Then after she has presented, probably she can present the case. We can ask questions. Then after the case, she can just probably review the literature for us so that everyone is aware of how to approach fetal ascites. So Dr. Gwanzura, you can start.
Thank you, Dr. Verenga. I will go ahead and start. I'm presenting a case of fetal ascites. I don't have good broadband, so I'm not going to share my video. So this is the outline of my presentation. I'll talk about the case that we saw on Wednesday, the 16th. It's bit about fetal ascites and the probable next steps for our patient. So I present to you Mrs. A.M., a 35-year-old self-employed lady from Harare. She's para 3 gravida 4 with 2 children who are alive. In her first pregnancy, she delivered a stillborn 4,000-gram baby at term. And during that pregnancy, she said she had severe hypertension. So it's been managed for severe hypertension, but couldn't quite say whether it was preeclampsia or not. The other 2 children are both alive. They were also born at term by vaginal delivery. She reports no consanguinity. She has no recent infections or contacts with people who had infections. There is no family history of genetic disorders or anomalies. So her initial presentation was on the 7th of December at a local clinic where she presented at booking with a 3rd trimester scan showing severe fetal ascites. At the clinic, they noted that her gestational age was 31 weeks. Based on that scan, she was normotensive, noted to be HIV negative. However, blood group and her RESA status, these tests were not done. Neither was the rapid plasma reagent test for syphilis. She was then referred to the fetal maternal unit because of the findings from the scan. She was seen on the 10th, which was 3 days later, by a senior resident medical officer within admissions, who noted a blood pressure that was elevated of 158 on 92 with a plus of protein and commenced on methyl dopa. She was then booked to be seen within the fetal maternal unit. The next 2 slides are basic. They're just for the beginners in the unit, similar to me. Obviously, she had come with severe ascites, so we were going to scan her abdomen as part of the fetal anatomical survey. So I got these guidelines from the ISUB website, where they note that when you are scanning the abdomen, there are 2 abdominal planes in transverse view that you want to look at. At 11, unfortunately, okay, yes, you can see my pointer, hopefully. At 11, that's just below the diaphragm. You see the stomach and the intrahepatic umbilical vein, and that's the area where you take the abdominal circumference. And at the code insertion, you also have to have another look there for reasons that will be discussed in other meetings. And that is a not so good picture of the plane at 11, unlike some of the images that we see on the Voluzon. But anyway, basically, you see the stomach, you see the single rib, you're supposed to see the umbilical vein, the liver, the spine, the aorta, and the inferior vena cava. I'm not sure why my slides are not advancing. Hello, can you hear me? Okay. Hello.
Doc, we can hear you.
Okay. All right. Sorry, so these were the findings that we saw on the abdominal plane when we're now examining the patient, Mrs. AM. And as you can imagine, this is the plane on the abdomen, that's the liver, and you can see the ascites within the abdomen. I think, Dr. Verenga, you can jump in to explain a little bit more on the images. And this is the plane where we took the abdominal circumference. And you can see lots of ascites, the picture that we took from the website. As we were doing the anatomical survey, we took a closer look at, on the previous image, we were trying to look at the gallbladder. These were noted to be distended loops of bowel during the ultrasound scan. That's within the abdominal cavity. We also checked for the single deepest pool, and it was well within normal limits. The placenta was also less than 6 centimeters. It was 5.2 centimeters, so there was no placentamegaly. This is a view through the chest. You can see the fetal heart there, and we have a small effusion that's about 1 centimeter deep. We also looked in detail at the heart. Everything was noted to be normal on assessment of the heart. And if you look at the normograms, here, the estimated fetal weight was 1,782 grams, which was within normal. The BPD was also within normal. The head circumference also just above normal, according to the normograms. And in terms of the Dopplers, the uterine artery Dopplers on the right and on the left had notching, as you can clearly see. There was also a high PI. However, other Dopplers were normal. The umbilical artery Doppler shown here was not in the MCA as well. There was no evidence of anemia, systolic flow. So a summary of findings, there were many pictures that were into here, but in view of the time I showed you above, in summary, we found severe fetal ascites. We found a small pleural effusion with well-developed lungs. We found distal large bowel distension. The left kidney was noted to be hydronephrotic. Sorry, I missed that picture, with dilated calyces with well-preserved cortex. There was a normal heart. The liver had no calcifications. And on Wednesday, when we saw the patient, we wanted to know her RESA status and Torch's screen. So these are the investigations that we ordered. We counseled her that the outcome was guarded, and for the time being, we'll be seeing her every 3 weeks for growth assessment, Dopplers, and we want to do a further assessment of possible hydrops and her gallbladder. So Dr. Verenga, I'm not sure whether you want me to stop a little bit now so that we can discuss a little bit of the history, or should I move on?
Yeah.
Hello?
Yes, Dr. Gwanzura, I think we need to stop for questions to allow people to ask you questions. Any question that may arise from your case presentation. The team member with you may also ask questions. Those who have questions but have no audio, you can put on the chat. If you have a question, we'll just give you 1 more minute. If there is no question, we will proceed with the presentation. Fair enough, yes.
Sorry, Dr. Gwanzura.
Okay.
Hello?
Yes, yes, I can hear you.
Oh, okay. You mentioned that this the fetus said there was fetal ascites and pleural effusion. Can we then say that this is hydrops fetalis since we have two collections of fluid in 2 or more compartments? Are we dealing with?
Thank you for that question. Thank you for that question, Dr. Chamnyonga. I am going to go into a little bit of a discussion about that, and you and the rest of the panel can help us to decide whether this patient has hydrops. I think there are 2 different definitions that I saw. If I can put a pause on your question and then delve into it as I discuss my my findings. So I think since there aren't any, sorry?
Any questions will be asked later. You can proceed with your presentation.
Okay. Thank you. So initially the patient was referred with severe fetal ascites. So I looked for the definition of fetal ascites, and this was noted as the accumulation of free fluid in the fetal abdomen. And this was quite clear from the scans from the patient that we took compared to the normal picture that I presented from the ISUG website. So this is considered one of the most challenging obstacles by sonographers, and they face it every now and then. Isolated ascites being the most challenging and rarely reported finding. So it's either you will find isolated ascites or you will find it in association with other conditions. So when it's isolated, you only find ascites and no other abnormalities based on the investigations. And when it is not isolated, this is where you find ascites associated with other things. So the first one here on my slide is any condition that results in hydrops fetalis. So I came across 2 definitions of this hydrops fetalis. It's either when you have excess fluid accumulation within the subcutaneous tissue and any other cavity within the fetus. So you have this subcutaneous edema underneath your skin, and then you find either ascites, pleural effusion, or a pericardial effusion. So if you find at least 2, so the the subcutaneous edema and an accumulation of fluid within any other cavity, then you would call that hydrops fetalis. And if we look at our patient, we didn't find any evidence of subcutaneous edema. She wouldn't meet that definition of hydrops fetalis. But then in other literature that I was looking at, it was only saying, and perhaps this was just my failure to understand, Dr. Verenga, you can help me, on the fetal maternal unit website, they just state that it is hydrops when you have an accumulation of fluid within at least 2 areas, and this can be your subcutaneous edema, your accumulation within the abdominal cavity, your pleural effusion, or your pericardial effusion. So by the second definition, she could qualify as having hydrops fetalis. I don't know whether you want to jump in here, Dr. Chamnyonga or Dr. Verenga.
Yeah, I think. Yes, Dr. Gwanzura, you are correct to say there are, let's say, 2 definitions which are found in the literature. But probably, I think you remember when we were discussing this case that one of the reason why we decided not to flag hydrops fetalis as the leading diagnosis is because of the clinical picture that we saw. Because a diagnosis of hydrops fetalis is a lot of connotations and a lot of meaning in terms of the prognosis of the baby, which we felt that this baby probably does not have that, the hydrops fetalis picture, because hydrops fetalis picture tends to be a very bad condition that is associated with the high intrauterine fetal demise. So I'm in favor of the first definition, to be honest, rather than the second, because the second will create a very wide spectrum of conditions where counseling becomes a very big challenge now, because a baby with, such as ours is highly unlikely to die inside the uterus compared to a baby who has the first definition.
Thank you, Dr. Verenga. I have no choice but to agree with you. So as I said, there are two types of hydrops fetalis, the immune and non-immune, and I won't delve into detail, obviously because of what Dr. Verenga has said. The immune hydrops fetalis is the one that's related to problems with antibodies on your red blood cells, the most common being rhesus status, where the mother is rhesus negative and the fetus is rhesus positive, and the baby gets anemic. And then the non-immune hydrops fetalis is as a result of a wide spectrum of causes, the most common being as a result of cardiac causes. That's why you saw us, we did a detailed analysis of the fetus's heart. It can be due to chromosomal problems such as trisomy 21, Turner syndrome. It can be due to infections. You saw us order a Torch's screen. In addition, you also have parvovirus B19 infection. I'm missing one of the most common. Anyway, I'll think about it as we go into the definitions. Or it can be idiopathic where no cause is found, or you can have this fetal ascites being related to bowel perforation. And I came across a case online where the fetus had a rupture of the appendix in utero and ended up presenting with fetal ascites. Or it can be due to ovarian cyst rupture in utero as well, intrauterine infections, hydrometrocolpus. I'll go into a little bit detail about that. Fetal urinary ascites from, for instance, transudation or rupture of the fetal urinary tract, for example, as a result of obstruction from a posterior urethral valve or a persistent urogenital sinus. So earlier I omitted to mention that the fetus that we scanned was a normal girl. So one of the differential diagnoses is of a hydrometrocolpus, where you have accumulation of mucus due to excessive stimulation from the mother's estrogen. So you have an accumulation of mucus within the fetus's hymen, within the fetus's vagina and uterus, where you have an intact hymen. And the picture somehow looks quite similar to what we described as the distended loops of bowel. So I found this to be quite interesting, an interesting differential diagnosis where you have a female fetus. So in terms of radiographic features, you find a free anechoic fluid within the fetal abdominal cavity. So that dark area that we saw within the scans that I showed you earlier. And the differential diagnosis, when you are looking at it on the scan, is of a fetal pseudo-ascites, where you have a hypoechoic abdominal wall muscles, or occasionally the hypoechoic fetal omentum, which can artifactually mimic a small volume of ascites. But in this instance, our volume of ascites was quite large, so it was definitely fetal ascites. In terms of investigations, when you come across fetal ascites, you have to have a detailed fetal anomaly scan, and that is what we did on Wednesday. And you are trying to look for other anomalies that may be related to, that may cause hydrops essentially, and may essentially end up causing an accumulation of fluid within the abdominal cavity. So we looked at the spine, trying to look to rule out sacral coccygeal teratomas, etc. You look at the brain, you look at the heart, you look at the whole fetus. Then you also do Doppler studies of the umbilical, middle cerebral artery, and ductus venosus, like we did. In our case, we had an increased, and diastolic flow within the ductus venosus Dopplers. You also do a fetal echo and an M-mode study of the heart. You also look at the placental morphology, and you also assess amniotic fluid volume. So in our case, the placenta was normal, there was no enlargement, and the single deepest pool was about 5 centimeters, which was well within normal. You can then move on to amniocentesis, particularly where you suspect, where you find an anomaly and you suspect there may be a chromosomal anomaly, such as trisomy 21, trisomy 18, 13, and Turner's. So you do your amniocentesis to be able to do fetal karyotyping. You can also do it to do PCR testing for the infectious agents, particularly the torches and parvovirus B19. And you can also do metabolic testing, especially in your history where your patient admits to their family having inborn errors of metabolism, etc. You can do codosynthesis within an FMU, where you look at the full blood count, blood group, and Coombs test of the fetus. You can also do a thalassemia screen where there is a family history of thalassemia in the patient. And you can also do a karyotype when you do a codosynthesis. There is also room where there is capability to do gross fluid collection of the fetus. So we could collect that ascitic fluid and assess a lymphocyte count, decide whether it's an exudate or a transudate. And when the fetus is born, you need a follow-up neonatal examination. Obviously, the neonatal outcome is important and their well-being. So those were the fetal investigations. On the mother, this is what we ordered. We ordered her RESA status. So this is done by the indirect Coombs test. We can do an infectious screen. So for our patients, we ordered the torches screen. You need to do a rapid plasma reagent test to rule out syphilis and parvovirus antibody titers. We also require to do a full blood count, blood group, hemoglobin electrophoresis, where there's a family history of the thalassemia disorders. Where you suspect a fetal maternal hemorrhage, there's room to do a Clay-Hill-Bedked stain to quantify the amount of fetal maternal hemorrhage, and other screens are done based on your history. If you suspect autoimmune disorders, you can do an autoantibody screen, and you can also do an oral glucose tolerance test where the history is suggestive of gestational diabetes. So in terms of management, counseling is very important. So we spent a bit of time counseling our patients. You need to counsel them about the condition, particularly where you have clinched a diagnosis. You need to then discuss the options that are available, the prognosis, and the importance of an autopsy in the case of fetal death in order to determine what the cause was. In 60% of instances, so this is Hydrops literature, you can clinch the diagnosis in utero, but when you then examine the fetus post-delivery, you can find the diagnosis in 80% of the cases. So there is a 20% that you cannot, where it will be difficult to find the cause of the fetal ascites. And also important in management is a multidisciplinary team management. So our team within the FMU, we need to liaise closely with the obstetricians and the neonatologists. We need their help in examining in detail the neonate post-delivery if the baby gets to term. Where there's need, we may also include clinical geneticists and other pediatric subspecialties, for instance, where we have ruptured appendix or imperforate bowel, etc. The specific therapy, of course, depends on the cause of the ascites. And in terms of follow-up, it scans every 2 to 3 weeks to monitor the evolution of hydrops, growth scans, etc. And also in the follow-up, it's important for the obstetricians and for our team to also monitor for maternal morbidity. If the fetus is hydropic, you can imagine that the mother can have Mira syndrome and end up with preeclampsia. Our patient already had a plus of protein with hypertension. This could be preeclampsia evolving or the Mira syndrome. And obviously the delivery method and timing depend on the cause. sorry, I just need to get to the slide where I was at. So in terms of what's there in the literature on isolated fetal ascites, if we assume that our patient had isolated fetal ascites, there was this study that was done in Egypt where they looked at 102 cases with fetal ascites. They found that in 72% of the cases of fetal ascites, they were able to find another anomaly. And in terms of delivery, 48% the pregnancies were discontinued either spontaneously or iatrogenically, and in 28% they reported to only have the isolated fetal ascites. In terms of what was missed, they missed about 9% of anomalies, and I guess these were noted when the fetuses had died or the neonates had been born and had died. And most of the cases with a positive pathologic finding were either a chromosomal abnormality or GIT malformation, which could be likely in our case since we had bowel distension or perforation. And in this review, they noted that isolated fetal ascites is actually a challenging obstacle. So you can see that we are dealing with a challenging case here. So if this is the end of my presentation, if there are any comments and questions, I will take those now and the team can assist me.
Thank you so much, Dr. Gwanzura. Let's ask you questions, or let's ask questions not only to you, but let's ask questions concerning the case. Probably while questions are coming, Dr. Gwanzura, I've some few questions for you. The first one is, what do you think are the prognostic markers which we have to look for when we come across a case of fetal ascites? Before you answer me, Lyman here is asking, Lyman Kumbula is asking if is there grading for fetal ascites mild, moderate, severe? Did you come across that? Mild, moderate, severe ascites.
Thank you for that question. Unfortunately, I didn't come across a grading for the ascites. Perhaps the floor can help me. You are not going to eat there.
Yeah, I don't know any grading, to be honest, but probably let's come back to my question of what are the prognostic markers which you, some of them probably mentioned them, but what are the prognostic markers would make you worry when faced with fetal ascites?
So when I'm faced with fetal ascites, if I identify another anomaly, that points to a poorer prognosis than just finding, I guess, the ascites on its own. So if they are, if perhaps there are cardiac defects as well, or if I have identified a cause that cannot be addressed. So for instance, if I get parvovirus B19 and we are unable to do intrauterine transfusion, or the gestation is still too early for us to deliver, then that's a poor prognostic marker. Yeah, so essentially, if there's also cardiovascular compromise, so that is the reason why we were assessing the ductus venosus Dopplers as well, to also find out if, as a result of that ascites, the fetus's cardiac cardiovascular system is compromised. That's a poor prognostic marker.
So much. Maybe the next question for you is, I think you mentioned counseling, which is a very important important point in the management of this patient. I think we have already highlighted that there is isolated or non-isolated ascites. There's something else which you mentioned in the history, which we saw on the examination, probably didn't ever overemphasize enough, which really makes me worry about this case. I'm worried about this because there's something which you highlighted on the images there. What do you think is the biggest worry? Probably I'll start with that. The biggest worry on the patient. If you go back to the images that you have shown, the bowels, let me just explain something. I think those images.
Yes.
So those images, I do not think they are the same. This image and the one with sepia. If you remember clearly that this one with sepia, we actually traced the bowels and we saw that they were communicating.
Yes.
Bowels and they were communicating this. They were not divided as we see on this cyst here. So they are not really similar images. You can see this one is a capsule, a very nice capsule. The one on the right, there's a nice capsule there. It's well encapsulated, yet this one just is the walls. So they are not very similar. Just explain to everyone that don't think that these images are similar. They are totally different images. Then you go back to the image. There's something which makes us worry about this case a lot. Which probably most people may not be checking properly when they are examining patients. If you can go back on the images to just emphasize a point. Yeah, go back again. Maybe go front.
Okay. I may have missed out some images.
Go to the front again.
Okay.
Wait there. No, okay. The one before.
The one before. Okay.
Something which makes us worry a lot. I don't know if you remember the discussion, something which we mentioned during the scan.
Yes, we were trying to look for the gallbladder to try to rule out biliary atresia. I think that was one of the things we were looking for in this image, and calcifications within the liver. That is what I recall.
Yeah. You are right in that the gallbladder is the biggest worry here, because the gallbladder looks a little bit echogenic and very tiny, which really worries us that there could be biliary atresia. Biliary atresia is a very big problem in our case where transplant services are not available. So there is a possibility that this baby could have biliary atresia as well. Of course, we are going to reassess the gallbladder on the next appointment, but the appearance of the gallbladder is so tiny with the echogenic walls as seen on the images, which really worries us a lot. Then on your investigation, maybe what would want to see being done is to try and sort of rationalize the investigations in reference to the case that you have presented. There are lots of investigations that books mention. If you let me just give you an example. Go to the investigation list so that I can just run down as an example. Yeah, to the investigation. Let's start with the fetal one to give as an example, so that we can rationalize. Right? Yeah, the investigation one. Go. Yeah. right there. So the one before Dr. Gwanzura. Right. There are certain investigations. You mentioned it right well that fetal karyotyping, we should offer it if we think there is a major defect or markers of aneuploidy besides the ascites on its own. So it should be clear to everyone that if we don't see any other findings besides the ascites or any strong marker for aneuploidy, there's no rationale in offering the woman amniocentesis for fetal ascites. Then the PCR testing for infectious agents, especially the torch group, we should be clear that we only do the PCR screening if the mother tests positive for torch. Because there is no way that the baby is going to get any of the torches virus without the mother having it, including syphilis. So it is only when the mother is a positive finding, and we've done the IgM and the IgG and also the avidity test, which probably one of you guys will tell us what an avidity test is. Probably we'll get a case of fetal infection very soon. So it is only after we've done the IgM and the IgG, and in pregnancy, we don't much rely on IgM because of the high false positive, but it is the IgG we want and the avidity test. It is only when these are positive and that will be worried about the fetal infection, we need to do this. So that should also be clear that screening for infection, first of all, you have to check the mother. If the mother is clear, there's no need to go on and do this kind of tests. Then, of course, chondrocytosis, let me say, it's that kind of investigation which is sort of fading away. It still has a role in cases of course, of intrauterine transfusion due to rhesus isoimmunization, and also cases of TEPS immunization, secondary twin anemia polycythemia sequence is still relevant. But again, the issues, all these issues will come into play if we have tested the mother and the mother is positive to any of the blood disorders that we think can affect the baby. Right, then the lymphocyte count, if we are doing an amniocentesis already, of course you can benefit by also doing aspirating some ascitic fluid from the baby's tummy, but we cannot just do it because we've seen ascites unless there's something pretty obvious. Then I think there's one test which you missed, which we know is not common in our setup, but everyone who sees a baby with ascites should know it at the back of their mind, because Zimbabwe has other races. You meet another race with you do to miss cystic fibrosis, because cystic fibrosis may also cause ascites, right? So it should be very clear that cystic fibrosis causes ascites, especially in the Caucasian race. There are races where cystic fibrosis is so common. Yeah, so I think this is what I wanted to emphasize, the rationale of the test, so that we understand the idea behind all the tests. But otherwise, thank you so much for your work, for this good presentation you've done. Yeah, I don't think there's any other question on the chat. Any other question before we end the meeting? Any other question before we end the meeting, guys? It looks like there is no other question. Thank you so much, Dr. Gwanzura.
Thank you.
The
Pleasure.
specialists are taking a break for 2 weeks. And also the presentations are taking a break for 2 weeks to allow for the festive season. So we will not be having meetings the next 2 weeks, the next 2 Fridays. And we want to wish everyone a Merry Christmas and a Happy New Year and a prosperous New Year. Enjoy the festive season. Please look after yourself. COVID is still there. And also those who travel, stay safe on the road. Thank you so much. And let's look forward to the new year as we continue to do more and more things for babies. So thank you so much. If there are no other questions, I think it's just fine to close the meeting. Thank you so much. Bye.